It's a very challenging situation because young women with hormone receptor positive cancer, estrogen receptor positive cancer, can benefit from the hormone therapy, but supposing they want to have a baby. You're doing a study. Could you tell me about this study? What exactly are you actually trying to do?
So the study is addressing young women who had breast cancer, early breast cancer before age 40, who are going into adjuvant endocrine therapy, and they want to have a baby. So the study is addressing to interrupt treatment for a couple of years to allow them to try to get pregnant and then resume treatment after they succeeded to get pregnant or did not succeed.
Right, so what's the nuts and bolts of what you're doing then?
So the goal is to allow women to try and have that break and have a baby, and at the same time optimize their breast cancer outcomes, because you can't generally get pregnant on the adjuvant endocrine therapy because it's contraindicated. It can cause birth defects and all kinds of problems, or you just can't because it suppresses.
You've begun already, haven't you? You've got some.
We've started the study, yeah.
Yes, we started, and last year now we have 25 patients enrolled in 8 countries and in 25 centers enrolling patients, and we are planning to widen up including centers to accrue more patients, because we have to go for 500 patients overall.
Now, here at the San Antonio Breast Cancer Meeting, we're hearing about wonderful advances in breast cancer, but how often do you, as doctors, encounter women who actually want to consider their fertility? Do they regard that as a high priority, do you find?
So we actually have some good data on this. Our group has looked at this, and it ranges from about 40 to 50% of women who are diagnosed with breast cancer under the age of 40 were not done with their families or childbearing at the time they were diagnosed. So this is a concern for that large group of women who are diagnosed at a young age. Whether or not they actually decide to pursue a pregnancy after diagnosis depends on a lot of factors.
What kind of advice do they normally get at the moment?
It depends. It's
not always good.
It happens that they are discouraged to have babies because they are endocrine responsive, and so they should not get pregnant because hormones are contraindicated and all this quite old stuff. And the additional problems these days is that the endocrine therapy is going on for longer periods, 5 to 10 years. And so many of these women won't have the chance to have a baby after they finish treatment. So that's why we decided to study to interrupt treatment to allow them to get pregnant, because otherwise they will be 45 or something like that, and the chance to getting pregnant afterwards are very low.
And there are lots of data that actually look at, is it safe to have a baby after breast cancer? They're all flawed in that nobody's done a randomized trial or even a prospective study looking at that. So it's looking back and saying who got pregnant and who didn't get pregnant. But even in those studies that are flawed and confounded potentially, the women who get pregnant actually seem to do as well, if not better, even early on. So that's some of the compelling data that said, we think it's probably safe. We don't know for sure. We need to test it because it's such a critical issue for these young women.
And current practice is what? Is it vague and
usually you should advise women to have at least 2 years. The data we have is that to encourage women to have at least 2 years of endocrine therapy and then maybe stop and try. But there is no prospective data, as Dr. Partridge says. So we have to go and look for this data and produce this data.
I would say that the practice varies widely based on the doctor and their understanding and their comfort level, based on the patient and their understanding and their comfort level and their desire to have a pregnancy. Some people want the pregnancy that they were diagnosed. They're at the OB's office trying to get pregnant, and some want to put it off and are comfortable with that. So this is not the right study for everyone. But I think the critical issue here is, can we get them some therapy, interrupt it, get them back on? And in breast cancer, it's such a long-term disease with ER-positive disease, and most women will be cured. Can we allow them to safely have a baby and still get great breast cancer care?
And this is the kind of study for women who decide even not to get endocrine therapy because they so much want to have a baby that they decide not even to start. And so this is the study for these women who do not dare to stop on their own. They really wish to have a baby, but they want to have this within a safe environment, which is a study.
What are your feelings about how safe it is? You say there's some positive data from what we have already that women do just as well, but what are the potential problems of stopping?
Well, I would just start with women who've had early breast cancer, it's all invasive disease, are at risk of hearing from breast cancer again, period. And they're living with that risk whether they get pregnant or not. And whether or not we don't think a pregnancy impacts on that risk based on the retrospective data, but we're going to look at that. But either way, they're living with risk. So that's one huge concern. Moving forward, becoming pregnant, and then having a recurrence during that time.
Okay, briefly, when are we going to get results, do you think?
Well, it will take a while. I think the first analysis will be done in 6 years from now, more or less, and then the final data we are following these women for 10 years, so it will be, quite a long time to go.
All the best studies need a long time,
yes.
without a doubt. And you're doing something called crowdfunding. What are your objectives in that?
Well, this is, of course, is not a funded trial because no drug company is interested. There is no drugs involved. And so we are looking funding for coordinating the trial to try to involve many more patients and clinics all over the world. And so this, of course, needs money.
Mm.
And we want to be able to accrue so that we can meet our goal, so we can really answer this question for folks, and it can be generalizable to patients all over the world, not just patients where, we get enough funding to accrue.
And to follow these women. And we have a lot of additional questions, psychological survey, and then, the healthy of the baby, and all this stuff, which are the characteristics of women who do not get pregnant. And so there's lots of research questions, and so we think that we will have a lot of data for the future women to be safe.
You have something called Big Time for Baby. What is that?
So this is an instrument, a tool, which was developed by the BIG because the trial is supported by the Breast International Group to try to address these issues to patients, to founders, and to try to make the trial available as much as possible and to raise money for this important trial.
So what would you like clinicians to take home from your efforts? Clearly a big message is to get over to women all over the world to support this very important project, but what should doctors take home from this?
I would say the first thing is open the study, put your patients on who are interested in having a pregnancy after early hormone-sensitive breast cancer. Obviously, this is not for the patient who doesn't want a pregnancy. That goes without saying, but you got to say it. And also, I think we need to support our patients in their overall kind of survivorship concerns. This is so important, and we need to study things like this. So get people on this study. Let's understand this issue.
Or refer people,
or refer
patients to other centers, because of course you cannot open the trial in every center, but refer people, even if you are skeptical as a doctor. Yeah. This is the opportunity. You refer your patients to a trial so they are followed, so they are safe within a trial.
The only thing I would add to that, the skeptical point, is this is a place where we have to, I think, kind of remove our own paternalism or maternalism and recognize that for an individual patient, their values about having a baby may be different than we think they should feel at that moment. And that's kind of hard, but we can do it.
And some of them will stop the treatment anyway.
Right.
Because their desire is so strong.
It shows what a powerful and important decision this is.
Yes, absolutely.